Shop. So thank you all for joining us. I am Jessica Petrie, Associate Director here at Kornhauser Health Sciences Library. And my partner in crime today is Dr. Mark Burns with the Division of Infectious Diseases. And anything else you want to add? You have so many credentials, Dr. Burns.
Yeah, especially since Dr. Ramirez left, I've inherited a few.
You're mixing and matching your hats, but we're glad to have you with us today. And a little background for everyone. We had a panel session on vaccines back in April that focused on the reasons people were or were not getting vaccinated for COVID-19. And it touched on issues like historical medical research abuses, inequities in distribution, access, and ongoing barriers to care, which generated some really excellent conversation. But we also had more questions than we had time for. And to preserve the scope of that session, we had to focus the ones we chose. And the ones that were outside of that focus were still really great questions. So we're bringing Dr. Burns back to ask him some of those that were more on the clinical, scientific, medical side of things that we didn't have time for, some that maybe we should revisit because we're always learning more, and maybe some new ones that we or you may have for him. So we will be focusing on that clinical science side of things and maybe limited in what we could share about active ongoing trials or unable to answer questions that are more about policy, implementation, mandates, that kind of thing. So to that end, I do have a list to get us started, but we want to really prioritize the questions that those of you that have been kind enough to join us may have for Dr. Burns. So we'll keep it conversational, relatively informal, but do ask that you type your questions in the chat as you think of them. And then I'm keeping an eye on it. We have a secondary host here at Kornhauser moderating that. And if you would need to speak your questions out loud, you'll need to raise your hand. And if we have time, we'll unmute you, but you'll need to let us know that way. So we'll get to as many as we can, but I will not hesitate to invite Dr. Burns back to talk to us again if we need to. And there will be an evaluation form in the chat at the end. If you could please fill that out for us, it will help us plan for future events. And all that out of the way, I think we're ready to get started. Are you ready, Dr. Burns?
I'm ready.
Okay. So jumping, kind of segueing directly from the vaccine panel, are you seeing disparities between the severity, the outcomes, the adverse reactions to vaccines or of the disease itself that are along racial or ethnic lines, that are based in pathology, physiology, genetics, biology, or are the disparities that we've seen so far primarily from those cultural or socio-behavioral barriers to care? That's a big one, but
yeah,
it's a good one.
That's it. You're right. I think more of the latter, because I think when you look at if you look at racial ethnic groups, for me, I've noticed pretty much the same. That is between our racial ethnic groups and the age. I've noticed they fall in one category versus the older folks of the same racial ethnic groups. And the way it's shaken out right now, it would appear that it's the younger ones. And when I say younger, I'm talking about those that are under the age of 45. So from 45 on down, because those are the people that coincidentally tend to be the ones who are unvaccinated. So those are the people that I'm noticing the disparity in. The people who are vaccinated, not so much in general. Now, there are a lot of people who are vaccinated who they have other, what I call comorbidities, okay? They have other type of immune problems. They're on medications to suppress their immune system and things like that. And coincidentally, the majority of them are going to be older as opposed to younger. So, but it's the younger ones that are a lot more I won't say vaccine hesitant. I'll say at this stage, I would call it more vaccine resistant than anything else. Now, there are a few that I've noticed that when you talk about mandates and work mandates, because of their jobs, they've had to get vaccinated, which has actually helped overall. But I think if it wasn't for the pressure of their employment, some of those folks would not be vaccinated. So, but again, if I had to draw a line, I would say the most distinct line is between vaccinated versus unvaccinated.
Thank you. So along those lines, we did get, now I have to theme some of these because we had several. I won't be reading them out loud just as they're written like a teleprompter most of the time. But we did get some interest in the testing of the vaccines themselves. So people may think they haven't been properly tested. Trials are still ongoing. We don't know if animal studies were, one of the commenters didn't know if animal studies had been done before the humans. And so could you share how we determine if a vaccine is safe and how that process might compare between pandemic times and what has happened with these vaccines?
Well, before the pandemic, the process was essentially the same, the process in and of itself, but the time was different on those. And what I'm trying to say is that it took a longer period of time for things to be tested, to be evaluated, and to be analyzed and then eventually approved. And we were talking, before the pandemic, we were talking about years. When the pandemic came along, so did Operation Warp Speed. And in essence, that sort of kicked into high gear, if you will, for the vaccines, their development to a degree, their analysis, that is looking at the testing when we talk about clinical trials, and then also to the actual distribution of it. And since the vaccines have been out, one thing post-pandemic that we have, in addition to the clinical trials, we have was what we refer to as real-world experience. That is looking at how vaccines have performed since they've been out. We found a lot of consistency between what happened in the clinical trials of these vaccines and our real-world experience. That is the continued efficacy of them. The only X factor, if you will, or the potential confounder, I would say, would be the variants that have developed as a result of the mutation of the virus. And that obviously we couldn't do before, because there weren't variants. But the great news has been, even though efficacy may have been down with the vaccines, they are still at a very high level. So in other words, they're still efficient and they're definitely still very safe. So that would be the major difference. One other thing I just wanted to mention, and I think people are more aware of this now, especially with the mRNA vaccines. It kind of seems as though they maybe came out of nowhere, but that's not entirely true. If people think back to the original severe acute respiratory syndrome, or SARS, that was out in about 2002. And then the second version of that, which was MERS, Middle Eastern Respiratory Distress Syndrome, around 2012, 2013, about 10 years later. The platform for the actual testing was actually being developed during this time, such that and it's kind of interesting. We noticed it was coming. Well, they had that 10-year wave and then we kind of anticipated in another 10 years we might have something similar, and almost on cue, we had the SARS-CoV-2. And even though the actual virus was slightly different, the platform used to test and rather to develop a vaccine, the platform of that was there. I sort of put it like this. It's kind of like, if you think back to early computer days, you had hardware and software, okay? Well, the hardware would have been the actual platform, what we're talking about for mRNA vaccines. The software would be, in this particular case, SARS-CoV-2. So whatever came along, whatever that quote unquote software was, we could plug it in to this hardware and get it to work. And working meaning we get the formation of the vaccine.
Yeah, that's a good example. I do want to at least try to rephrase part of that, because it gets really complicated.
Mhm.
And I think something that's hard for a lot of people to understand is why the studies were able to be conducted so much faster. And you mentioned it, but I think it's worth mentioning again that in a pandemic situation, the volume of people that are exposed or being infected is a whole lot higher than in a non-pandemic situation. So that the opportunity for comparing how many people were exposed to how many people were vaccinated and did not eventually become ill, or the mortality rates after those vaccinations, it speeds up the process because you don't have to wait years and years and years for example, and we don't have a vaccine for this yet, but for an Ebola outbreak to come back and have more of a population spread that we do not want even a little bit, but that is how we know if it's affected in the real world, that difference between efficacy versus effectiveness that Dr. Ramirez was all so good at explaining. And the difference between how it works in a lab, in a petri dish, of how the vaccine interacts with the bug, with the pathogen, versus how the vaccine affects a person who is exposed to the pathogen, and how that works in real world spread. We're able to observe that at an increased rate. Unfortunate for a whole lot of reasons, but that is what allowed the speed of development to be sped up, to go to warp speed.
Yeah, because not many of us were around during the last pandemic, so we don't really know exactly, how to approach this. And another thing I tell people as well, when I hear people say, well, they were developed too fast and things like that, and I always bring up the point, well, horses and buggies were good, when they first came out, but now we have, we're going from diesel engines, now to electric engines. Okay, so in other words, we are advancing. So why can't our testing, our evaluations advance as well too? So I think that's going to be part of the equation, and I believe going forward in development of things, going again from years down to maybe a year or much less period of time being involved, basically.
So I'm going off script. I don't even have this as a question on here, but when it comes to that accelerated rate, how do you think the access to information has changed that? So last pandemic, people were encountering Spanish flu for the very first time and siloed in very distinct ways because the communication technologies and the dissemination of research and medical information was a very different world. It was several different worlds away from where we are now. What role do you think that increased access to previous generations of research and sharing concurrently as things are discovered has sped that up too?
Sure. Well, I think twofold. Number one, and most importantly, we have that thing that we call data. Okay, we have information, and we're getting information not only from our source where we are, but now because of technology, we can obtain data or information from all over the world. And by getting all this data and also analyzing this data, and by the way, our means of analyzing data has advanced as well too. So I think it's a combination of gathering more information, data, and analyzing this information, because getting it from all these different sources from everywhere has never been like it has been before, especially when we talk and we think about the computer age in and of itself. And then not only that, but the actual analysis, we even have help analyzing data, picking out a whole lot of different points, and we even have now programs to help us correlate the information and help segregate it, set it out, and help us draw conclusions on it. So bottom line, we have much more data than we did, and secondly, we have even an advanced way to analyze all this data. So, I mean, we can't help but advance, given those situations.
Speaking of data, so we got a question about VAERS data. So the vaccine adverse events reporting system. So people have seen that, and it shows that there have been however many deaths after a vaccine that have been reported through the system, or how many adverse events. Could you explain a little more about what VAERS? I don't even know if that's a acronym people abbreviate that way. I've never heard anybody say it out loud, but we're going with it for now. Explain what that is and how that data should or maybe should not be interpreted.
Yes, yeah. The VAERS system is sort of like a people who have problems, or that is, they've received the vaccine and maybe they felt they had a side effect or something that happened, or an adverse reaction or adverse event. That stuff is reported to the CDC, and what they do is they get that information and they correlate it and they analyze it. If you think back to when they were talking about the Johnson & Johnson vaccine and the issues they had with that, with the thrombi and the coagulation issues that came up. A lot of that was as a result of being reported through that system. Again, it's given to the CDC, and there are people who are watching it, who are analyzing that. And I believe it's I think it was more of the adverse events that they were looking at, and trying to see if there was any kind of correlation with things. That way they would sort of stay ahead, if you will, if there were problems resulting from the vaccines.
Great. So yeah, that is a system that who can submit to that?
Anyone can, because there's actually a number. There should be I think it's an 800 number that you can call and report those things to yourself. But yeah, there's it's sort of like it's a hotline number, if you will, and you can call and report those types of things that do occur.
So that allows anybody at all. It's usually clinicians that would use it and know about it, but anybody can report what's happening with them after a vaccine. And it allows the I think it's co-sponsored, CDC and FDA together, but
Yes.
they will look at that as a they're casting a really wide net, so to speak. They're collecting all the potential data so they can keep an eye out for patterns that should be investigated. These are not, this isn't filtered data in any way. It's not confirmed correlation versus causation necessarily. It's a way to provide a really large scale monitoring system for response to public health emergencies, and allow the people that need access to that data to see it and observe the patterns and identify what needs to be looked at. I think that's really important for everybody to remember, especially people who can see these really scary numbers that come out of there. And you have to remember that is the data that is being reported to the CDC. It is not data that has been confirmed to be because of a vaccine. It is being reported to the CDC, not reported out from the CDC as confirmed or accurate.
Yeah, there are some things that healthcare providers are required to report. They have like a whole list of adverse type of reactions, and then if the person has like a reaction that was listed by the manufacturer as a contraindication, to further dosing of the vaccines, then they have to report those things. And as I said, there's a number that you can call. There's also you can also submit a report online as well too. But those are the primary ways that they are reported to the CDC. It's CDC and Health and Human Services, actually.
Right. So we have somebody who wanted to know, or a few. This is another one that I've themed and combined.
Okay.
People seem to be interested in the difference between, say, what we're calling PASC, the post-acute sequela of COVID, people who have had COVID and then don't get their sense of smell back for months and months and months. They're hearing about long haul COVID, long haulers, but we're also hearing about SARS-CoV-2 infections that last a longer time than we would expect. So could you explain the differences, if there are any? What's the difference between like a post-viral fatigue syndrome as opposed to PASC or long haul COVID?
Okay. Well, let's see. Well, when it comes to long haulers is what we're calling them, being post-COVID. Right now, we don't know exactly who's going to get it and who won't get it. Okay, that's kind of first and foremost. Secondly, we're not sure how long these last as well, and these kind of studies are still ongoing. Some of the symptoms are very similar to the actual COVID symptoms, themselves. And the ones we talk primarily about, you hear people talk about increased fatigue that seems like it persists. People who continue to have shortness of breath, breathing issues. A lot of people may have chest pain or abdominal pains that is like in the stomach. Some may have headaches. Some may also have difficulty with their concentrating and thinking. That's what we ultimately call the brain fog, those types of things. Other people, they, as you sort of alluded to, they have a prolonged loss of their taste, of smell, of taste and smell. Some people may have um, uh, uh, generalized sort of joint muscular pain, and all these things can be attributed to viral type infections. But again, right now there's no real rhyme or reason as to, number one, why they occur, number two, who's it going to affect, and number three, how long they're going to last. Again, studies are ongoing investigating this.
And is there a sense of if the pathology, the illnesses that people are experiencing post-COVID, the fatigue, the brain fog, the muscle, the myalgias, do we have a sense of if that is a separate process entirely, or is it COVID lasting a long time?
Well, it's hard to say. I do not believe it's the COVID, that is the SARS-CoV-2 infection in and of itself lasting, because that's relatively short-lived. Okay, but it's just the effects, the damage that it causes. If you know the pathophysiology of what's happening, and it actually, just like any type of viral type infections, viruses can't reproduce on their own, which is why they invade us. They need us. They need our cells to reproduce themselves. And by doing this, it can cause damage ultimately in those cells. HIV is notorious for this as well too. What happens is the virus comes in and it sort of commandeers the things that we use to reproduce our own cells. They take it over, reproduce more of the cells. They cause damage, in this particular case with HIV, to CD4 cells, and those damaged cells get destroyed. When enough of those get destroyed, you have a decreased number of infection fighting cells, which will leave you open to opportunistic type infections. Well, pretty much the same thing is going on with SARS-CoV-2, in that it affects different types of cells, cells in your nasal passages, your lungs, your heart, your kidneys, your digestive tract, even in your brain. It can affect all those types of cells, and it can cause damage ultimately to a number of those cells. And right now, we still don't have a good handle on how long. Let's say, for example, if a person does have brain fog as a result of the destruction and the actual process that SARS-CoV-2 has affected on it, how long that lasts. We don't know. Those studies are still ongoing. So it's kind of hard to say, again, who's going to be affected and for how long. So right now, we're just taking down data and just watching and just kind of seeing, what happens.
We have somebody who wants to understand more about natural immunity and how it compares to vaccine immunity. Do we know how it compares, if the vaccine is better or not? There's references to a immunity study from Israel, which I'm sure you've heard about.
Yeah.
We don't have to get into the weeds with individual studies, but just a general summary of what the evidence is showing at this point.
Okay. Well, okay. Now, a person that gets infected with SARS-CoV-2, yes, they will generate antibodies. Okay, and they will generate antibodies against that particular, let's say, for lack of a better term, that particular brand, if you will, of SARS-CoV-2, because we all know there are mutants that are out there. But there's two things we don't know. Number one, those antibodies that are quote unquote naturally generated, we don't know how long they last. Secondly, we don't know but we have an idea that these antibodies that are quote unquote naturally generated, yes, they work well against that particular COVID. So if, let's say, if we would turn the clock back to January, a person got infected with COVID, chances are it would probably be what was known as the B.1.1.7 or the alpha variant. Okay. But fast forward to June 2021, you get infected with COVID, is most likely going to be the Delta variant. Okay. And we can't say, but chances are the antibodies that were generated against the alpha variant, the B.1.1.7, most likely will not be as effective, if they are effective at all, against the Delta variant. Because remember, the virus has mutated. The virus will do what it can to survive. And it does that by mutating. And by doing that, the virus realizes that it's getting destroyed by the way that it's being attacked. So it's going to change some things so it can survive. So that's why those antibodies that are really generated against the quote unquote, the natural immunity is generated against the particular brand, if you will, of COVID, will likely not cover or not treat you or help you very much if you get another variant. Now, what they have shown in studies, that people who, if they do have natural immunity, if they get vaccinated, then they not only have more antibody production, but they have a robust response, producing much more antibody. And remember, if these are vaccine-induced antibodies, the vaccine has been effective against all the variants thus far. Then those antibodies that are generated as a result of being vaccinated would more likely be treatable when it comes to other variants, particularly in this case, we'll say the Delta variant, as opposed to the quote unquote natural antibodies. So even if you've had COVID, it is still incumbent upon a person to get vaccinated. And again, that will help them in the long run.
So some of these are general public questions. Some of these are other healthcare provider questions. Some of these, and some of the best of these, are healthcare providers asking how to explain things. The people that have submitted questions want to know questions they should be prepared to answer. Mm-hmm. So one of the things that was mentioned in that context is people who are using the variants as examples of why vaccines don't work. So if we can't guarantee that, just for example, if we can't guarantee that the Pfizer vaccine would prevent or protect somebody against future variants, what's the point of getting it? And you've touched on this with the immunity discussion, but they didn't phrase this as a question. So I'm going to keep talking and I'm just going to let you fix whatever I get wrong. So it's my understanding that the mutation opportunity for the virus, because it has to live in our bodies, can't survive without a host, which means it can't mutate without a host. If there are enough people in the population who are vaccinated, even if that vaccine only protects against the alpha variant, if that alpha variant can't get anywhere and survive long enough to reproduce, then it will protect against the development of future mutations, even if it can't protect against inoculation with future mutations that may come down the road.
That's 100% correct. The way I phrase it is, if it can't replicate, it can't mutate, okay? And if a person is vaccinated, people are vaccinated, okay, the virus has no place to go to replicate. And if it can't replicate, it can't mutate. That's it. That's in a nutshell. But you're 100% correct.
I have learned some things already. Look at that. So would you say, this came up two different ways, but would you say that people who have been vaccinated need to worry about quarantining after the vaccine? Or do they have to worry about viral shedding? Or is there anything that people do day of the vaccine that would impact the efficacy? So, a while back, there was a bunch of like rapid fire conflicting information about ibuprofen and NSAIDs, and like, you don't want to take this because to help with the pain because it'll decrease. And then some were like, you got to take your Tylenol or it won't work. And what will make side effects worse or better? What can people do to make sure they get the most out of their vaccines, I guess is where this one's going with that.
Okay. Well, as far as the Tylenol discussion, or let's say pain control discussion, we'll just make it generalized like that. It's not recommended to take it before you get your vaccine. Not recommended to do that. But after you've gotten your vaccine, and let's say your arm is hurting because the pain, it usually takes a little while for the pain to start up. If let's say it's to a point where you really can't tolerate it, then it's okay afterwards if you wanted to take something like something for pain control, Tylenol, or should I say acetaminophen, or some type of non-steroidal anti-inflammatory. It's okay to do it after you get vaccinated, but it's preferred not to do it beforehand because that can interfere with the generation of antibodies, that is, generation of an immune response.
Great. So this one is kind of interesting. And it may be touching on current developments and more policy side of things, but if we have people who are getting vaccinated who are also getting COVID, how do we rely on testing? How does testing play a role going forward? Should everyone get tested every time they have allergy symptoms just in case? Should they be testing regularly just in case? Someone commented that they don't feel they can trust their vaccinated peers any more than they can trust the unvaccinated peers, because we have no idea of who is walking around and giving COVID to colleagues unknowingly, because they believe the vaccine prevents 100%, or they've kind of let their guard down after their vaccinations.
Okay, I would say before the Delta variant, okay, if people think back, if you were fully vaccinated, and they've actually shown that fully vaccinated people before the Delta variant had very little what we call viral load that they were carrying. So such that it really was not being spread, again, with the previous variations of COVID. Now, unfortunately, the Delta variant, in its ability to survive, had changed itself such that when people who are fully vaccinated, if they were to, whether knowingly or unknowingly, if a person was exposed and if they did have a breakthrough type infection, then yes, it would be possible for a fully vaccinated person, even though they may not be symptomatic, that it would be possible in that case where they could spread it because you have such a high viral load. It was 1,000 times more higher than it was with let's say with previous versions of the COVID, whether it was the original wild type or if it was one of the earlier variants. So in that particular case, yeah, it actually could have been, it could be spread like that, which is why we still talk about, even though if you're fully vaccinated, if you're in an enclosed area, it's still recommended that you wear a mask. People who are unvaccinated, it is always recommended indoors or outdoors that they should still wear a mask. People who are indoors vaccinated, you want to make sure that you're in an area where you still have great ventilation, in addition to continuing the public health measures that people probably know ad nauseum. Okay, the social distancing, the washing hands, the wearing masks, those types of things. So yes, because of the Delta variant, even if a person is fully vaccinated, if they're still indoors in an enclosed area, they should still wear a mask.
And we do have one in the chat, and I'm going to try to answer it because I think I know. In the chat, we have someone asking, is it correct that all of the COVID vaccines do not cause viral shedding? And what I understand about that is that would depend on where you are, because for a vaccine to cause viral shedding, it would have to contain live virus and none of or at least weakened virus or something like that. And all of the US authorized vaccines do not have virus in them.
Correct. That is correct, because the mRNA, you did it. The mRNA vaccines, remember, they're only, they put on the messenger RNA the codes for the spike proteins only. So when a person gets an mRNA vaccine, and without going through a long physiologic discussion, just suffice it to say that when it enters a person's body and it starts replicating, it's making spike protein only, no viable virus. So there's nothing to be shed. And you're 100% correct. And by the way, those are the mRNA vaccines. The Johnson & Johnson vaccine, which is an adenovirus, that is, as you said, an attenuated virus or weakened virus. So it's actually, it just survives long enough to bring in those things that can help reproduce spike proteins. Then that's it. That virus is destroyed very, very easily by our immune system. And so suffice it to say, as you indicated, the vaccines do not make virus that is shedding. So a person who's been vaccinated, they do not shed virus, not from the vaccines.
Great. And if people who are vaccinated, should they quarantine if they think they've been exposed?
I always recommend that they get tested. Now, there's some arguments. Some people say, well, if you're fully vaccinated and you don't have symptoms, then you don't need to be tested. That's been out there as well too. Let's see. I think the CDC's position, because they've changed, they kind of changed about this a lot, and it's not that. And the changes are not because we don't know, it's because these variants that we deal with. Earlier, again, with the alpha and the beta variants, there you could definitely say if you're fully vaccinated, then you didn't need to quarantine afterwards. But now, because, as I sort of alluded to, because of the high amount of virus that a person carries as a result of the Delta variant, then I don't think they have to quarantine, but they should be tested. And of course, if they're symptomatic, then they should. If they're symptomatic, they definitely should quarantine. Definitely should. But if they're not symptomatic, they're fully vaccinated, I believe they should be tested.
Thank you. So we have concerns about how and why does infection still happen after vaccination? People who have been vaccinated have contracted COVID. So there's a difference in mortality rates and there's a difference in severity of illness, but that matters less and less on an individual level. That's important on a macro level, but to a person, that's still very scary to know that it can happen after vaccination. Could you explain a little bit about why? Why does that happen? And how that process works. What does the vaccine do and not do, essentially?
Okay. Well, number one, being fully vaccinated is the best scenario. But you have to understand, you have to remember that these vaccines are not 100%. Okay. So it is possible to have breakthrough infections. The thing about it, though, is that in the vast majority of people who have had breakthrough infections, the vast majority, they have done the major things. That is, they've decreased hospitalization and decreased death, okay, among those people that are fully vaccinated. Now, people who may have been vaccinated and got COVID and died, I use Colin Powell, General Powell, as a perfect example here. To look on the surface, they say, oh, wait a minute, he was fully vaccinated and he died, so the vaccines must not have worked. Well, hold on. Let's look at this total picture. In his particular case, he had multiple myeloma. So he had a predisposing, or should I say, comorbid condition that did not allow his immune system to generate adequate amounts of antibodies. So even though he was fully vaccinated, I don't know if he had a booster or not either. But suffice it to say, because of his comorbid condition, in this case, multiple myeloma, or anybody that has any type of immunodeficiency or problems producing antibodies, that they are still going to be at higher risk, but they're still more protected and safer and better off being vaccinated as opposed to being unvaccinated. So still no guarantees, unfortunately. But the other thing too is looking at breakthrough infections and looking how many have occurred. Now, if you say, for example, we've had 100,000 breakthrough infections, you would think, oh, wow, that's just horrendous. But you have to look at the total number. That's 100,000 out of how many millions of people, okay? And it's still a very small number. And the last count was like less than 1%. So still, the vast majority of people, who are fully vaccinated, the vast majority are protected against COVID. But remember, they're not 100%. Breakthroughs can occur, but even if you have a breakthrough, chances are you're not going to be hospitalized and you won't die.
Is it even theoretically, I know statistics, but is it possible to create a vaccine that is 100% preventative, or are most of them more along the lines of risk reduction and decreased severity of illness if it is contracted?
I believe the most are more toward the latter of what you mentioned. There are, when we talk about vaccine efficacy, the major thing that we've been comparing it to was like the flu vaccine, initial. Flu vaccines, if we got 50, 55, even close to 60% efficacy, we were jumping for joy, shouting, okay, because that's great, okay. So when the mRNA vaccines came along initially, and with their high efficacy rate in the mid-90s, okay, that was just totally unheard of. And it's still unheard of with any vaccine, getting that kind of efficacy. So yes, number one, I don't think there's going to be a vaccine to get 100%. But I think if you couple the vaccines that are high efficacy, and this actually is going to include the Johnson & Johnson as well too. Even though Johnson & Johnson is down a little bit from the 2 mRNA vaccines, it still has an extremely high efficacy rate. You take that, coupled with mitigating measures, that's going to put you about as close to 100% as you can expect to get. So that would be, again, no vaccine in and of itself is going to be 100%, but it's a combination of things that will get you as close to 100% as possible.
So we have two more in the chat with 6 minutes left, but I think you can probably answer them in the same
Sure.
response. So the forms of the vaccines we have right now, the Pfizer and the Moderna that are available to us at this point, does it cover all the known mutations? And what are your recommendations about boosters?
Okay, well, the answer to the first question is yes. They're still effective against all the variants. Now, just now, with full disclosure, knowing that they may not be 95%, okay, and as the variants go along, that efficacy rate does decrease. I would venture to say, I don't have hard data, but I would venture to say that, well, you're going to get a diminution of that effect. So instead of being 95%, they may be 80% effect. That's still extremely high when it comes to efficacy of vaccines. So, but the answer to the question, yes, the ones here that we use in the US, the 2 mRNA vaccines, the Pfizer, Moderna, and then also the Johnson & Johnson, they do work, they are efficient, and they work and they're safe against all the variants of COVID right now. Now, the other part of your second question is actually, it's been answered by Pfizer and is being answered even as we speak with the Johnson & Johnson and the Moderna, and that is booster shots. And they did say and I'm just going with the Pfizer because since that's the one that's been approved officially now. The Pfizer, they say 65 and over, or if you're older than 55 and you have a comorbid condition, or you work in an environment that you could potentially be exposed, that is a high risk environment. Okay, and also people that work in sort of a public service area, like grocery workers, people that are exposed to the public, EMS workers, people that could potentially, because of their job, be exposed, quite frequently. Yes, though they are recommended.
Great. I think you covered all the populations they're recommended for too. So ages, comorbidities, occupation. Are there any other groups that should be considering it?
Well, as I mentioned, we're in a period right now where there's a lot of change, a lot of flux going on. So I predict that the J&J and the Moderna are going to be approved as boosters, fully approved. The FDA has approved them. Now the CDC has to review all the evidence, and I feel very strongly they're going to approve it as well too. So that's one thing. Also, boosters vaccines for children 5 to 11, that's ongoing right now as well too. And I predict probably around the beginning of November that, again, they go through the process. You have an advisory board for the FDA, and then the full FDA panel. You have the advisory board for the CDC, and that's the Council on Immunization Practices. And then presented to the CDC. And when all that comes together and everybody agrees, then that's when it'll be officially recommended and given emergency use authorization to be able to be given to children ages 5 to 11.
Great. So we should have the evaluation up in just a second. There it goes. In the meantime, since you did mention children, and that's one of the questions that we haven't gotten to yet, we appreciate everybody being here. Fill out the evaluation if you can, but if you want to stick around to hear this answer, feel free to do so. We had some questions about why last year it seemed like kids weren't contracting COVID, or it was assumed that either there was something about kids' immune systems that would prevent it, or if it was related to school closures. How have you seen cases case rates among children changed since schools have reopened in person?
I believe it's a combination. Number one, as you just said, reopening of schools, kids being exposed to each other. In some places, and I'll be as nice as I can, that they forbid mask mandates, which makes my head explode. But anyway, that those types of situations occurring. But also coupled with that is the fact that we're dealing with variants, and in this particular case, the Delta variant. And because of its increased transmissibility, it has affected more children. It has put more children in the ICUs, and unfortunately, it has killed more children than the original wild type or the variants shortly after that. So this is only becoming more and more contagious, which means it's easier and easier for kids to get. So that's unfortunately that's what's happening. So again, the best thing we can do is, especially for our children, number one, getting them vaccinated, of course, when that official recommendation comes down, and I believe it will. And secondly, putting as many vaccinated adults around them as possible will help protect them also. So I think it's going to be a combination of those things to help protect our children.
Sure. So we are at time. I'm going to turn the last question around on you and say, what is a question that you wish people would be asking, or is there anything you want to share that we haven't asked today?
Well, I'll just say this. You hear about people. You hear about the adults being upset at meetings about children, school boards and things like that, about them mandating or wanting to mandate children wearing masks. And as soon as vaccination gets approved, that's going to be out there on the table as well. I would just say this. I wish people would ask, what do the doctors say? What do the experts say? Okay, if something's wrong with my car, okay, I'm not going to go to the bakery and ask a baker, what should I do about my car? I'm going to go to a mechanic or somebody that knows. So to me, I think they should be asking experts in the field as to what's recommended, what should we be doing, okay? Because that's what experts are for. Now, a person may not want to hear what the expert has to say, but the expert is just that. They have experience, they have knowledge. They've been trained in a particular field, and those are the people that you want to ask. Those are the people you want the information from. Okay, so I wish people, instead of asking certain leaders, now the leaders can consult with the experts, and they can form their opinion based on consultation with the experts. But I wish that people would just talk to people who know, and then you may not like the outcome, but the people who know are going to know better than them usually. So that's the only thing I would have to say.
That's a good one to add. Thank you so much for joining us. Thanks for talking to me this afternoon.
Thank you for having me. I really appreciate that. And I'm more than happy to come back at any time to answer any questions about anything COVID or whatever.
Snacks.
Whatever we
come up with.
I do need a snack. I do have some crackers here. That'll be my snack.
We'll let you get to that. We appreciate everybody who joined in the audience and submitted questions. We will have the evaluation survey link will be live for a while if you want to fill that out now or later. And we will be sending out a link to the recording to everybody that joined if you'd like to share it beyond this group. Thank you all. and have a good rest of your afternoon.
Okay. Thanks, Jess.
Bye.
Bye-bye.